So welcome. First of all, I would introduce my first speaker, Professor Luhadia, from his Professor Emeritus at Department of Respiratory Medicine, Geethanjali Medical College in Udaipur, India. I cordially invite Professor Luhadia to deliver the first talk on NTM Pulmonary Diseases, a practical approach. Over to you, sir.
Good morning. Greetings from India. Namaste. Thank you, chairpersons and dear colleagues. I will be sharing my views on the practical management of NTM disease. To diagnose and treat NTM is not very difficult, but the only thing is that you have to keep this entity in mind and follow the guidelines. When I joined respiratory medicine way back in 1976, we hardly see cases of NTM, but in the present century, we are diagnosing more and more cases of NTM. I think both things are responsible. Prevalence has increased, but now we have got more diagnostic methods to identify this disease. So practically these two things are possible for increase in the prevalence of NTM. Now, why NTM is important for pulmonologists? Because it mimics tuberculosis and many of the chronic pulmonary conditions like bronchiectasis, ILD, particularly hypersensitivity pneumonitis. And if it is not kept in mind while treating tuberculosis, we may misdiagnose the case as drug-resistant TB. As compared to tuberculosis, the diagnostic and treatment strategies are different, and treatment outcome is poor as compared to tuberculosis in these cases. That's why it is important to keep this entity in mind. Now, while managing such cases, there are few steps which I would like to highlight. Basics for the diagnosis, then followed by species identification, then initial drug sensitivity, then which case requires treatment, that is very important. Then regimes are different for different species. Surgery may be complementary to the medical treatment and follow-up strategy. So these are the points which we should keep in mind while treating or while considering NTM. Now, when to suspect NTM? It is common when there is recurrent symptoms after treating a case of tuberculosis or chronic lung diseases like bronchiectasis, COPD, ILD, etc. When HRCT is showing a persistent cavity, fibrobronchiectatic changes or nodular lesions, and patient is immunocompromised. So in that situation, we should suspect, because unless you suspect, you will not be able to diagnose. The diagnostic algorithm, very well designed by the ATS guidelines. We have got three types of samples with the patients. We may have sputum. If no sputum, then we may go for bowel and bronchial aspirates. And if it is extrapulmonary TB, then we can go for biopsy. And of course, culture is the gold standard for the diagnosis. The criteria are different. For sputum, two culture should be positive. For bowel and bronchial aspirate, only one culture. And for histopathology, one culture or histopathology, both are required. Preferably, when we suspect NTM, we should order culture over the liquid as well as solid media to enhance the yield. What I do personally in my institution, that whenever I get sample of a sputum, I usually advised sputum AFB smear, gene expert, and culture when I am suspecting NTM. Because if sputum for AFB is positive and CB0 is negative, then it is likely to be a case of NTM. So in that situation, we should focus on culture, and once culture is positive, we can go for further testings like molecular tests. If sputum is heavily positive, then we can directly proceed for the molecular test, but the gold standard for the diagnosis is culture. Why species identification is important? Because in tuberculosis, we don't go for any species identification. We just start treatment. Once we know the case of tuberculosis and rifampicin resistance, we start the treatment. Because it is an environmental bacteria, so diagnosis is when same species is identified twice in sputum, then we establish the diagnosis. Then DST has to be ordered according to the species which you have identified. Treatment regimes will differ as per the species, and prognosis will also depends upon the species responsible for NTM disease. The species identification may be done gold standard with the culture and biochemical test, but nowadays we prefer molecular test. RT-PCR, LPR, or whole genome sequencing is quite helpful in the early diagnosis as well as species identification. There are some few tests also, but not recommended in the guidelines. MALDI-TOF, that is a mass spectrometry related test. Now, once you have established the species for NTM, then next step will be that you should know what is the initial DST. When you first time diagnose the NTM, then you should go for initial DST only. Extended DST is not required, and it is according to the species. In MAC cases, if it is a non-severe or mild case, then you may avoid initial DST. But if it is a severe disease, then you must go for DST for macrolide and amikacin. If it is CanCC, then rifampicin sensitivity should be ordered. And if Mycobacterium abscessus is there, any of the species or subspecies, then you should go for amikacin and macrolide DST. So according to species, you order the DST test. Once DST is available to you, then you have to decide whether to treat or not to treat that case, because every NTM will not require treatment. Because, for example, a minimal or mild MAC disease may not require sometimes treatment because the disease course is quite indolent. And few studies have shown that up to 30% cases, there may be spontaneous conversion in such cases. So they may not progress, and the treatment duration is quite long, and unnecessarily if you have put him on treatment or her on treatment, there are significant toxicities with these drugs. And of course, the outcome is poor in majority of the cases of NTM. So you should be very cautious whether you should start treatment or not, and proper counseling of the patient should be done, because at the end you may not deliver the proper things to the patient as required by him or her. So in what cases we should wait? If it is a mild disease, particularly MAC is mild disease may not progress. If the species is less virulent, which has been isolated in your patient, Mycobacterium gordoni, cheloni, or fortuitium, because these species are known for poor progression of the disease or may not cause active disease. When the sputum smear is scanty positive in your case, the patient is immunocompetent and is a young and healthy patient. So in such cases, you may wait and watch for the treatment. Now, once you have decided to treat your patient of NTM, then go according to the species and initial DST. The most common NTM encountered by us or reported in literature is MAC, Mycobacterium avium complex. Now, when you decide the regime for MAC, consider two things. What is the severity of your case and what is the macrolide sensitivity? Severity is that when symptoms are extensive and radiologically there is cavity disease or extensive disease, then it is severe. If there is no cavity, limited disease, nodular or bronchiectatic, then it is non-severe or less severe disease. So according to that, you decide the regime. If your case is macrolide sensitive non-severe disease, then we choose rifampicin, ethambutol and any macrolide out of clarithromycin or azithromycin. But usually we prefer azithromycin because it is easy to administer once a day or it is also effective intermittently. Now here the only point which I want to highlight that in non-severe cases, intermittent therapy is as effective as daily therapy. And the only difference in the doses is that in intermittent therapy, you have to give ethambutol in the higher doses, that is 25 milligram per kilogram body weight. Otherwise, the doses are same. So you can choose either intermittent or daily for non-severe macrolide sensitive case. If it is a severe disease and the bacteria is macrolide sensitive, then you can go ahead with rifampicin, ethambutol, macrolide. These three drugs are usually sufficient for these cases, but if any of these drugs cannot be used or there are extensive clinical symptoms, there is a lot of toxemia, then in the initial few months you can add aminoglycolides like streptomycin or amikacin, but that is not mandatory. Mycobacterium malvoescens also we can use this resin, though that is not a common pathogen encountered in day-to-day clinical practice. Now, if you are not able to use these drugs which I enumerated, then there are alternative drugs like rifabutin, clofamazine, amikacin inhalational preparations, which may be used as alternative drugs or salvage therapy in these cases. Now, if your patient is macrolide resistant disease, then you can go with rifampicin, ethambutol, INH and moxifloxacin. 4 drugs are to be given because macrolides are the main drug for the treatment of NTM. Again, if any of these drugs cannot be used or extensive clinical symptoms, then you can give a support of aminoglycosides in the initial phases. If the bacteria is Mycobacterium cancer, then you have to design the regime as per the rifampicin sensitivity. If it is rifampicin sensitive bacteria, then you go with rifampicin, ethambutol, and either of INH, clarithromycin or azithromycin can be included, and these 3 drugs has to be given daily. Intermittent therapy is not recommended in such cases. Now for Mycobacterium cancer, I would like to say that once it is isolated, these cases should be treated because it has been observed by the literature that cancer usually progress to the active disease. So these are to be treated once you come to know that the case is having Mycobacterium cancer. If it is rifampicin resistant disease, then INH, ethambutol, one of the macrolide and moxifloxacin, these drugs can be included in your regime in a daily manner. Though it is very less common, Mycobacterium genopi, but if it is there, then it also causes severe pulmonary disease and it should be treated like a severe MAC infection with 4 drugs, rifampicin, ethambutol, macrolide and INH or clonolone. Now, Mycobacterium abscessus is the most notorious NTM and difficult to treat. If it is Mycobacterium abscessus, then you should go for subspecies identification because the prognosis is different. It is better with Mycobacterium abscessus macillens subspecies. Otherwise, for abscesses and volatile, it is relatively poor. Now, This is the bacteria where none of the first-line anti-TB drug is effective. Here we have to use multiple antibiotics, and the drugs available for the treatment of abscesses are, for the parenteral, among the parenterals, amikacin, tizicycline, imipenem, cefotoxin. Then among the oral drugs, macrolides, quinolone, clofamazine, linezolid, cotrimoxazole, minocycline, etc. And inhalational drugs, amikacin. So treat it, if it is microperitoneum abscesses, then always treat it like a severe disease, most difficult to treat. Macrolides are the most effective group of drugs in this, and their treatment should be individualized. When it is macrolide sensitive, then we have to use at least 3 drugs, or you can use 4 drugs, macrolides plus other drugs as shown in this slide. If it is macrolide resistant case, then 4 to 6 drugs, minimal 4 drugs are to be used, and out of this list of drugs you can use. But here I want to say that you can add macrolide in this group, not as an active drug, but as an immunomodulator. It will improve the results. The alternative regime, which is also in the literature, is that you use all intravenous drugs plus azithromycin for 4 weeks, followed by amikacin, clofazimine, any of the one drug of these oral antibiotics, and azithromycin for the rest of the duration. Chalone is again a rapid grower but less common. The surgery is complementary to the medical treatment, so it is for localized lesions, it is good. Treatment failure cases where repeated NTM is there, you should go for extensive DST and treat as per DST. Adjuvant therapy not recommended in guidelines, but these are the things which have been mentioned. And I think out of these, granulocyte macrolide colony stimulating factor may find some role in the treatment of NTM. The minimal duration should be 12 months after sputum conversion, but in Mycobacterium abscesses, sometimes because of the toxicity, we may have to give multiple short courses of antibiotics. In the follow-up, again, sputum culture should be done during the active treatment, and even after stopping treatment, you should go for culture every 3rd month till 1 year, because relapses are quite common. CT thorax not routinely required in the follow-up, but if indicated, you can go for CT scan at the end of therapy. So just to conclude my talk, treat NTM if it is required. Treat as per species and DST. Duration should be 12 months at least after sputum conversion. Treatment outcome is not very good in these cases, so explain to the patient and follow the patient with sputum cultures for 12 months even after stopping the chemotherapy. Thank you. Jai Hind.
Our second speaker is Dr. Keith Hatthotuwa. He does not need any introduction to our audience here. And he's a consultant respiratory physician and general internal medicine and senior lecturer in respiratory medicine, Broomfield Hospital, Essex. What do you say?
Aibowan. So hope I get this right. So why is non-CF bronchiectasis important? So it's a very common disease, and we all think of this as part of COPD or asthma. It is basically an increasing prevalence of this condition. And unfortunately, it's such a common thing, but yet we treat it as an orphan. Nobody wants it. So it's important to try and recognize we got to do something more. And if you think about the prevalence in China, it could be even as high as 1 to 2%. So therefore, there's basically an increased prevalence also seen in the United States. So we unfortunately, in spite of being such a common disease, not many studies, no more data around this. So therefore, something needs to be done. And therefore, it's we also get quite a few rare conditions. And even those rare conditions also, we're still not sure, should we be doing something more different for them? And so basically, to date, we have no standard therapies purely for bronchiectasis. We are treating them as they got asthma, COPD. That's what we are doing. So now this is where the EMBARK study came about. And in 2015, and this is thankfully under James Chalmers' stewardship, you might say, and we created the EMBARK study. And I'm also proud to say I'm one of the people who contribute, and we got a couple of dedicated nurses who pick up all these cases. Soon as I get a case of bronchiectasis, we have to fill in this quite detailed, it's almost about 10-page long pro forma, we fill them up. And now when you look at the EMBARK data, you can see by far the majority are going to be idiopathic. Now, even yesterday, the president was mentioning that in Sri Lanka, it is tuberculosis. Right? And yet now, when you look at the data around the world, you can see also this is quite different. So where do we see? And if you look at around the world, basically, even USA, they will say most of it is all immune related. Whereas if you go to more countries like in the India, Sri Lanka, then it's quite reasonable to say, yes, it's probably all due to bronchiectasis. But you also know increasing prevalence of COPD, asthma is being seen in these countries too. Now, what was interesting with the EMBARK study is that when you look at the microbiology, by far, the most commonest organisms we pick up is actually Pseudomonas and Haemophilus, and Moraxella is also picked up. And it's very interesting when you look at the spectrum of disease or microbiology, you can see for some strange reason, you might say, is the southern European countries have got more Pseudomonas. Now, excuse me. So we suspect this is because there may be not much antibiotic stewardship. So they are just probably getting willy-nilly loads of antibiotics, whereas we are very clear in UK, we should make sure we are getting proper cultures being sent off and make sure what we are treating. Now, we already heard Professor Denning also mentioned that even the normal lung will have some fungus, and therefore it's important to understand the concept of the microbiome. So we were all taught that the lung is entirely sterile, but it may not be necessarily the case. And it's all about what sort of pathological process is taking place in the lung to create this. So let's look at some of the important EMBARK data facts. And we got well over 17,000 cases that have been analyzed since 2015. So they locked down the data set to analyze in 2022, but the data is still ongoing. We are still collecting more cases. And needless to say, the UK was one of the highest contributors. And that probably because James Chalmers is in UK and is really pushing all of us around to collect data for him. And look at this. Females are more common or prevalent in getting bronchiectasis compared to males. And when you look at the spectrum of mild, moderate, or severe, roughly each will have about 1/3 each. So 33% mild, 33% moderate, and then we probably may argue there's a bit more severe cases. And most of the cases picked up in the EMBARK study now, 75% of the cases were due to either idiopathic, post-infective causes, COPD, asthma, and tuberculosis. So you're not wrong in thinking that tuberculosis is the main problem. It depends on each country. And what was the highest comorbidity picked up? It was cardiovascular disease and anxiety, depression. Now, all of us have been taught saying that COPD, asthma, bronchiectasis are obstructive lung disorders. But increasingly, when you look at the data set in the EMBARK, we get lots of PRISM cases. And PRISM is trying to say that you got preserved ratio impaired spirometry. And some of it may be due to the fact that lots of the airways may be just clogged up with mucus and therefore causing a degree of restriction because of the collapse, preventing the obstructive element coming through. And more than 30% of patients were on inhaled steroids. Now, we tend to really give too much inhaled steroids in this group. And the data also showed 20 to 30% also had eosinophilic inflammation. So therefore, you might argue, well, why not give them inhaled steroid? And 1/3 of patients also were considered as having frequent exacerbators. So in bronchiectasis, we call somebody being a frequent exacerbator if they're getting 3. Causes slight confusion because in COPD, we'll say if you've got 2 exacerbations per annum, that's a frequent exacerbator. But in bronchiectasis, we say 3. Now, it's important to try and work out the bronchiectasis severity index. And this is quite a good thing to work on. So it's looking at what is their body mass index, look at the FEV1 predicted, look at the previous hospital admissions, and has the patient been hospitalized with a severe exacerbation in the last 2 years, and the number of exacerbations in the previous year, and looking at their modified MRC breathlessness score. And we try and work out whether they're colonized with Pseudomonas. And quite often we find colonization with Haemophilus is also seen. So if I get a case of Haemophilus, we tend to try and first of all see whether we can sterilize them, and we give at least about 2 months of doxycycline. Now I'm lucky I can do that in the UK, and when it comes to summertime, I say use some sunblock, but you can't probably use much doxycycline over here because of the phototoxicity it might cause. So just bear that in mind. And part of the bronchiectasis severity index is worth working out how many lobes are involved. Is it just 1 lobe, two lobes, or 3? And now looking at the bronchiectasis severity index, one of the independent predictors of future hospitalization include prior hospital admissions. That's pretty obvious. And looking at their MRC breathlessness score, and clearly if you've got somebody who's much more breathless, again, not a surprise if they come into hospital sooner. If they got quite severe airways obstruction, again, we see them coming through. And Pseudomonas by far is one of the commonest reasons why they come into hospital. What about the mortality? Clearly, if they're much more older and they got very low lung function and low body mass index, this is just like in COPD. If you have got patients who are looking quite cachectic, bad prognosis there. Now, I just thought I'll throw this in if you want to have a simple way of trying to have some sort of score. You can use the phase score. But I think the bronchiectasis severity index is probably far more important. And why? Because based on that, you can see if you've got mild bronchiectasis, you can see you got a much better prognosis. And you might say the mortality rate is quite low. And you might say the chance of getting admitted is about 3.4%. And the mortality over 4 years, as you can see, is quite low. On the other hand, if you've got a bronchiectasis score of 9, then you might say they have a much higher degree of hospitalization as well as a much more higher mortality. Now, I thought it's worth just to focus a little bit on COPD. And you can see COPD, you can see probably has a much worse prognosis. But one of the things you must remember with bronchiectasis, they don't really have that much parenchymal disease. So the actual lung parenchyma is reasonably normal. It's just that a predominantly an airway problem. And also you need to bear in mind, these guys with bronchiectasis have a much worse disability and poor quality of life. So therefore, they're not going to die that soon if you might argue. Therefore, treat them very aggressively to get them better. So what should we be doing better? We should be clearly identifying traits or so-called clinical phenotypes or heterogeneous endotypes. And then it's worth looking at whether this inflammation we are talking about, is it eosinophilic or is it neutrophilic driven? And that's why it's useful looking at their blood counts and looking at sputum samples. And about 42% of bronchiectasis, they will have some degree of reversible airways disease. That makes it also difficult. So are you going to treat these guys with inhaled steroids, or are you going to use just simple dual bronchodilators? And it's worth thinking in those lines. Now, I quite often, in some patients who say they are not breathless, they don't have eosinophil count, I actually withdraw their inhaled steroid and just give them a dual bronchodilator. And obviously, must make sure we are still doing the chest clearance and use drugs like carbamazepine, and even once daily N-acetylcysteine is used. Particularly patients find a tablet burden is huge. Now, we should try and see whether we can change the microbiome, and that's what we're looking at a bit more in the future. We'll be looking at that with the research. And clearly, vaccination is important. So I will recommend all my patients to have their flu jab, and I will also tell them to have their Haemophilus jab also, as well as a pneumococcal vaccine. And what about beta mucolytics? And now, they did try some studies. They did try to use Dornis alpha, which, as you know, is licensed in cystic fibrosis, but the data was disappointing and perhaps suggested that it could make matters worse. So therefore, we don't use that in our non-cystic bronchiectatic patients. Now, should we be using other drugs to try and target the so-called neutrophilic? And roflumilast is there, but roflumilast, though it's much more cleaner than theophylline, unfortunately, it still causes problems with weight loss, and people do find it's not very well tolerated. Now we are lucky. We are getting to a better time of life, I think. We now got a couple of new drugs. And so we'll go through the 4 drugs that we got. So Aricacy is now available in the UK, but it's really expensive. Therefore, you got to show that the patient has got refractory NTM. And then you can give this treatment even up to 18 months. And it's licensed to do that. And obviously, it has got limited clinical safety and efficacy. So we need to still be careful that we don't create any further problems. And we do not give each and every patient Aricacy. And there's funding in the UK. Now, I don't know how much it'll cost if you want to bring it up here. And the main side effect is increased respiratory adverse reactions, including bronchospasm, hemoptysis, which you might argue probably is going to happen anyway. Now, I'm really excited with this drug, brensocatib. It's the first ever DPPI inhibitor. And now it's basically, I suspect this will soon come into approval and be used in the USA. The Willow study, which was a phase 2 study, clearly showed there was a huge benefit. And there's 2 doses being tried. And the Aspen study, which was done, phase 3 study, clearly has shown that there was much reduction in the exacerbation and also time for the next exacerbation. And therefore, the dose is given as either a 5 milligram or a 10 milligram dose. Now, Jamie already mentioned this drug, ensifentrine, which is actually an old drug. And basically, it's not licensed for bronchiectasis. But if you are already using drugs in asthma, COPD, in bronchiectasis, why not this? And one of the nice things, and Jamin already mentioned this in the morning, that one of the nice things it does is probably improves ciliary function. And it can act as a bronchodilator, and it might reduce the inflammation. And so it's already licensed in the USA, and you give them nebulized 3 milligrams BD alongside their normal medication, but including the chest clearance. And the main side effect is, again, paradoxically, bronchospasm. Now, I just thought I'd quickly mention this drug. This is basically not licensed for bronchiectasis. And the only reason I mention this drug here, because it might be some of the cases, we do still get a couple of cases which have got pretty resistant hemophilus. And this drug might be of some value if you want to treat patients who are still not responding with your standard treatment for hemophilus. But you need to be careful again about QT prolongation is a problem with that. Now, I want to very briefly tell you a few more drugs. I'm running out of time. Now, already it mentioned in the morning about dupilumab. And certainly, I can see some of our patients who are getting frequent exacerbators, perhaps if they're eosinophilic driven, then yes, we can think about using dupilumab. Tezspire, you also heard Hitesha mention this in the morning, early on, and mentioned that it certainly reduces the mucus production. So therefore, this is also something that we can think of. There's also more newer drugs coming through which are still under trial. And the latest data that's come on is yet another drug similar to brensocatib is going to be available, another cathepsin C inhibitor. Alpha-1 proteinase inhibitors also been trialed out, and then phage therapy has also been thought about. And we are also looking at inhaled PDE4, and KAC already got that drug which I'm looking at, and that also may be interesting because it might be able to target that neutrophilic inflammation. So I'll quickly finish off. What can we do better presently? We already mentioned that. We need perhaps have much more potent antibiotics for Pseudomonas. And maybe we need to have more inhalers, which give us a bit more choice. Why should it be that I should have a triple therapy, which only has an inhaled steroid? Why can't I have a triple inhaler, which may have something to target just the neutrophils? And then you might say, can I have all four? So we might have a 4-in-1 inhaler. And watch this space. And we obviously need more pediatric studies. We are still not talked about pediatric. We always still not got any data. We are treating them as mini adults. And we probably need to have a bit more so-called trials looking at antibiotic duration. How often should you give it? Has it got to be PO, IV? Are we giving combination? We don't have any of that data. Thank you.
Thank you, Keith, for this excellent talk on bronchiectasis. The privilege of inviting our previous speaker, Professor Luhadia. I'm honored to invite him again. He will be talking again on prevention of next exacerbation of bronchiectasis. Over to you, sir.
Thank you, Chair, sir. The previous speaker has made my talk easier. He has almost given the background of bronchiectasis nicely. Since it's an chronic disease and associated with often known exacerbations, and in majority of the cases, the treatment is lifelong. So prevention and treatment of exacerbations is very important. And antibiotics are playing a major role in the treatment and prevention of exacerbations. So I'll focus and I will limit my talk to the antibiotic strategies only. Rest of the things my previous speaker has already dealt with. The most common symptom for the exacerbation to diagnose in a patient of bronchiectasis is, I think, sputum volume, increase in cough and purulence. Rest of the symptoms, if they are present, then we can diagnose. If these are showing deterioration, we can diagnose as exacerbations, provided we should exclude the fresh or new diseases like lung abscess or pulmonary tuberculosis. Now, every exacerbation is affecting clinically the cases of bronchiectasis. Once there is exacerbation, then it increases the risk for the future exacerbations, increases the rate of hospitalization, mortality, morbidity, and that's why quality of patient becomes very poor. Now, before I go actually to the antibiotic strategies, I would like to discuss one of the case which came to me few months back. He was 50-year-old male and having a background of respiratory symptoms for last 20 years, along with recurrent respiratory tract infections in childhood. For the last 5 days, he had increase in the cough and expectoration along with fever. The expectoration was huge. In the last 1 year, he had such 4 exacerbations and hospitalized once. On clinical examination, the classical findings of bronchiectasis were present. The investigation record showed that his sputum was repeatedly negative for AFB by smear examination, and the last culture, which was performed 3 months back, showed Pseudomonas species, and present counts were raised with neutrophilia. X-ray chest showed bilateral disease, heterogeneous opacities, and left side in the retrocardiac area, multiple translucencies. So clinically, radiologically, we suspected bronchiectasis, and the CT confirmed the diagnosis, bilateral bronchiectasis and partial collapse of the left lower lobe. So now this was a case who had bilateral bronchiectasis and he was in acute exacerbation. Now, before we start treatment, as rightly said by previous speaker, that we should try to phenotype our case, what phenotype you are dealing, because according to that, if you treat, then the results will be better and you will be the exacerbations may be minimized or prevented. The various phenotypes are shown in this slide. So most commonly we come across the frequent exacerbators, as previously it has been shown that about 1/3 or to 50% cases in our country are having frequent exacerbations. Rest of the phenotypes required some specific modification in the treatment according to the etiology or clinical phenotype. So as per this table, my case was a frequent exacerbator. The various treatment strategies available with us to treat bronchiectasis and to prevent exacerbations are antibiotics, airways clearance techniques, then of course these drugs, supportive drugs. But here I would like to say that vaccination is very important, which is most of the time when I come across the prescriptions of my previous treaters of that patient, that vaccination is missing in the prescription. He's getting a lot of drugs and antibiotics, but vaccination is missing. So what I would like to request, that vaccination should be a part of treatment for bronchiectasis. Now, why antibiotics are important? If you look at the most common hypothesis responsible for bronchiectasis is the vicious cycle hypothesis. Here, whenever there is chronic bacterial infection, then it will exaggerate this cycle and will lead to increase or progression of the disease and repeated exacerbations. So it is very important to use antibiotics judiciously and with a very good strategy, because you have to treat this case for lifelong and lot of antibiotics are to be given to him. So you should be very particular regarding antibiotic treatment. The treatment strategies of antibiotics will depend upon three things: severity of the disease, pathogen responsible for the exacerbation, and the phenotype of the patient. Severity of the disease, very well dealt by my previous speaker. These are the parameters which he has discussed, and these are the severity scores which will decide by whether the disease is mild, moderate, or severe. Very nicely discussed by my previous speaker. Now we come to the actual antibiotic strategies. Now, before we design any antibiotic regime for your patient, you have to see these things. How to select antibiotic in your case? What should be the number of antibiotics you will use? What route you should choose? What should be the pattern of administration, that is continuous or cyclical? Cyclical means off and on periods. You give antibiotic, then you have an off period for antibiotics. What should be the duration of the treatment, whether it is short term or long term, and whether you require eradication of the pathogen or not. Because in every pathogen in chronic infection, it is not necessary to eradicate the infection. So, number one point, how to select antibiotics. It is usually based on the previous culture report, and if it is not there, you have the knowledge of your area, epidemiological data for a pathogen in your area or in your hospital or your institute. If it is not there, then you can start the antibiotics empirically according to your clinical judgment and send the sputum for culture. If culture report is available afterwards and patient is not improving, and then only change the treatment. But if you have started empirical antibiotics and your patient is improving and the culture report is otherwise, please don't change the antibiotic. See the response. Regarding the number of antibiotics, your patient is a mild or moderate disease, then use single antibiotics in the initial cases. If it is a severe case or the pathogen was multi-drug resistant, then you choose more than one antibiotic, that is multiple antibiotics. Again, for the selection of the route, if it is mild or moderate, then you go for oral antibiotics. Or if it is severe disease, then go for IV antibiotics. Or your oral therapy is not possible, then you can go for IV antibiotics. Inhalational antibiotics are to be reserved for long-term treatment, or you have to extend the short-term therapy for eradication of the pathogen, because the availability of the drugs which are used in inhalation is less and they are costly, as very nicely spoken by my previous speaker. So you have to be very cautious by choosing the drugs and route of administration. Regarding the pattern of administration, usually the daily or intermittently, that is twice or thrice a week, is a preferred mode for administering the antibiotics. But if you are going for long-term treatment or your case is refractory where you are going to treat for a very long time, then you can go for a cyclical administration, that is, you administer drug for 14 days, then don't administer for 14 days, or 28 days, or off drug 28 days. In that manner, we can go ahead for long-term treatment of our cases. Usually, the duration for acute exacerbation, because the various studies have shown, they have compared the 7 days, 10 days, 14 days, 21 days, and 28 days duration, and it was found that 14 days duration is sufficient for treating acute exacerbation. And sometimes you may extend the duration, particularly if you are dealing with MRSA pathogen. Extended duration for 4 to 12 weeks is usually required when you want to eradicate the pathogen, whichever you have isolated. And long-term treatment is usually reserved for frequent exacerbators, where we use 6 to 12 months therapy, or maybe more longer than that. For the long-term antibiotics, the various guidelines and various meta-analysis have shown that macrolides are very effective orally. And if macrolides cannot be given, the doxycycline is the another choice. And for inhaled drugs, many studies are there, and they have shown that these drugs, colistin, tobramycin, amikacin, gentamicin, ciprofloxacin, estromine, even levofloxacin, they can be used by inhalational route. IV or oral antibiotics in a cyclical manner is reserved when you want to give treatment for a very long duration. In refractory cases where you give drugs for off and on, for a off period and on period, or you can give 2 to 3 months antibiotics, then gap, then 2 to 3 months in refractory cases. Now, while going for long-term antibiotics, it should be preferred that same antibiotic should be continued rather than monthly rotation of the antibiotics, because studies have shown that better policy is that you should see the same drugs for longer time. Now, there are some cases where the exacerbations are more in the winter season or change of season. The summer months are relatively having less of the exacerbations. So what you can do, that you can observe an antibiotic holiday while providing long-term treatment during summer months to decrease the load of the antibiotics and economic load to your patient. Then last point, deciding the antibiotic strategy is eradication. Whether you, in such cases, whether eradication should be tried or not. It has been shown that if it is a Pseudomonas infection, first time isolation or it is a new isolation, then only eradication is required. If it is a chronic colonization, even for Pseudomonas, eradication is not required. So eradication should be reserved for new or first time isolated Pseudomonas. Few of the studies have shown that MRSA should be eradicated, and then in those you can extend the treatment. So now with this background, these are the various studies. Now how these strategies to be applied to our patients of bronchiectasis, let us discuss. If your case is a mild to moderate bronchiectasis with acute exacerbation and the pathogens are known Pseudomonas, then single oral, or if it is not tolerated, IV antibiotic, targeted or empirical, is sufficient for 14 days. In these cases, eradication is not required, and in few cases when MRSA is there, then you may go for eradication. No long-term antibiotics are required in such cases. You treat the exacerbation and then maintain the case with the air physiotherapy and airway clearance techniques, vaccination, etc. Anti-inflammatory drugs you can use. Now, if your case is a mild to moderate bronchiectasis with acute, but here Pseudomonas is the culprit. Now, in these cases, again, if it is a mild case, single targeted antibiotic for Pseudomonas or IV antibiotic according to the situation of the patient, 14 days course. Then, if it is a new isolation or repeat first time isolation, then go for eradication with the inhaled drugs for 4 to 12 weeks after a course of 14 days. Again, no long-term antibiotics in these cases are involved. Maintain your case with the other therapies, that is physiotherapy, vaccination, etc. Then another situation can be that your patient may be in severe bronchiectasis with non-Pseudomonas species acute exacerbation. Now here a combination of antibiotics will be required, more than one targeted antibiotic, usually for 14 days. And treatment may be extended if the clinical response is poor. Otherwise, studies have shown that even in these cases, 14 days antibiotic course is sufficient if it is a non-Pseudomonas pathogen. Eradication again not required. And if the case fails, then you can go for repeated courses of antibiotics. No long-term antibiotic again for non-Pseudomonas pathogen is required. If it is again Pseudomonas species with severe bronchiectasis, you have to use combination antibiotics for 14 days, followed by inhaled antibiotics for 4 to 12 weeks if it is new or first time isolated Pseudomonas infection. So here, if it is a new Pseudomonas or first time, then you should go for eradication. Now we come to the most common variety which is causing discomfort to the patient as well as doctor is frequent exacerbator. If the pathogen is non-Pseudomonas, then treat the acute exacerbations first effectively. Because if you want to prevent next exacerbations, treat present exacerbation effectively and then put the patient on long-term antibiotics. Here the role of long-term antibiotics comes in frequent exacerbators. If it is non-Pseudomonas, that macrolides are the first choice, followed by, if it is not tolerated or not effective, then you can go for doxycyclines or inhaled antibiotics, or you can use a combination of inhaled antibiotics and macrolides. Even if the case is not controlled, then you can go for cyclical administration of IV antibiotics for every 2 to 3 months if the exacerbations are more than 5 per year. If it is Pseudomonas, for frequent exacerbators, because this is the most common situation which we encounter. If a patient is frequent exacerbator, then the most common pathogen responsible will be Pseudomonas. Now here the inhaled antibiotics are first choice, followed by macrolides and then combination. But in our countries, because inhalational antibiotics are not readily available and they are costly, so we are following the macrolides first, and then we can go for addition of the inhalational antibiotics. But the guidelines say the reverse. These are the ERS guidelines which says the same thing. These are the BTS guidelines which also say the same things. Now coming back to my case, here it was severe bronchiectasis with frequent exacerbation. So we put him on antibiotics initially for Pseudomonal infection, and then the symptoms were extensive. So we preferred inhalational tobramycin and azithromycin in that patient. We are continuing treatment with that, and now he is better. So just to summarize my talk, once you diagnose bronchiectasis, then according to phenotype, severity and pathogen, treat the case. And even then, if he develops acute exacerbations or repeated, then divide your case according to severity, mild, moderate, severe, frequent exacerbator, and then pathogen, and then accordingly treat. Here I would like to mention that if a chronic colonization of Pseudomonas is there, it does not require eradication. Thank you. Jai. I am thankful to the organizers of this conference, particularly Dr. Niranjan Disanaike, for inviting me for these 2 lectures. Thank you.
Thank you, Professor Luhadia, and both the speakers. The audience is open for any questions. I'm sure the speakers will take the questions.
Yes. I very nice talks. Thank you, both of you. I have 3 comments. 2 for Prof. Luhadia, first of all. One, it seems that Mycobacterium xenopi or xenopi has a much worse prognosis than the other mycobacterial species with NTM. Do you know why? And do you agree with that comment?
This Xenopi is having worse prognosis as compared to MAC and CanCC you want to see. I have not come across the such literature, but I feel that probably the IgG system is affected with this. So there is immunity defect in those cases. That might be the reason.
Yeah, I think you may be right. The second point is that Korean doctors have made a lot of work on NTM plus chronic pulmonary aspergillosis. And if you have both of those infections, the prognosis is much worse. So one of the things that I feel is that if you have a new NTM infection with cavitary disease, so not bronchiectasis or nodular disease, but cavitary disease, you should actively look for CPA with Aspergillus antibody in cultures. And it's more important, particularly with the MAC infection, to treat the aspergillosis than the MAC, because the MAC has a relatively good prognosis, whereas the aspergillus has a poor prognosis. Would you agree with that?
Definitely, it should be investigated in such cases because both the diseases are more common in the suppressed patients. So I
Yeah,
think
but
it should be.
These
should
are not
be
immunocompromised. These are normal people with
Pardon?
NTM. These are not immunocompromised patients. These are normal people with NTM infections. So they're not immunocompromised with CPA and NTM.
I think it should be investigated in these cases, CPA.
And for Prof. Keith, could he comment on Aspergillus bronchitis? Because we heard a lot of information about the antibiotic therapy, but with bronchiectasis, you also can get Aspergillus bronchitis as a complication, separate from ABPA, which is another complication, but bronchitis. And where does that fit in the investigation and management style for non-CF bronchiectasis? So that's for Prof. Keith, actually.
Thanks, David. That's a good question. Yes, so I agree. I mean, I send us sputum samples regularly looking for typical or atypical mycobacteria and fungal cultures. And I must say it's depressing that I don't get any results coming back about fungus. Now, I do routinely check on serology also, but then as we discuss, serology sometimes will be almost always slightly high in this case, and that doesn't really indicate that this is the disease. So the question really is, if we suspect, particularly if it's cavitary disease, should we be treating them somewhat empirically, thinking that there may be fungus in this, making the condition worse? And again, obviously, I'm not sure if there's any data out there, and it's also about bearing the toxicity, safety. And would you be happy if we were to say give them a trial of, say, itraconazole for at least 4 months?
So the Aspergillus bronchitis is particularly a problem in bronchiectasis, non-CF bronchiectasis, band CF bronchiectasis. And they don't usually have cavitary disease, they just have bronchiectasis. And they almost all have concurrent bacterial infection. So you will find your Pseudomonas, you will find your Haemophilus, your Klebsiella, whatever you find anyway, but they have Aspergillus as well. The reason you don't find it is because the culture is insensitive, because the methods used in the labs are for bacteria, they're not used for fungus. So we have found when we plate the whole specimen, we can find fungus, or when we do PCR for Aspergillus. So I think there's some work to be done on PCR. But we have to find it twice to diagnose bronchitis. A few have positive Aspergillus IgG, not IgE, IgG. And our experience is that a 4 months course of itraconazole or voriconazole is successful, but they often relapse afterwards. So we give a course, we treat the bacteria and the fungus together. And the response rates are fantastic in some patients. Not everybody, but some of them are wonderful. So I think this is an area of needing some more research, I think, and work.
Thank you. That's very helpful. As I said, we do need more data to support because a lot of patients, and including the GPs also, we ask them to prescribe these drugs. They get really and truly nervous about the monitoring and giving these drugs. And I'm sure in your setup, you may be having much more nursing support. And it's difficult in secondary care, particularly if you don't have any nursing support to monitor these patients, looking at the toxicity side of things.
Yeah.
Thank you very much. Thank you very much. With the time factor, we are winding off the session, and we had a very good, interesting session on bronchiectasis. We must thank our two speakers with our usual manner, and thank you very much for your contribution. Thank you.
Thank you, sirs. Let me invite our honorable chairpersons, Dr. Ishant Perera and Dr. Saman Kapilavanshan, to present the token of appreciation and the certificates of our esteemed speakers, Professor S.K. Luhadia and Dr. Keith Hatthotuwa.